there was an announcement last month that actress Glenn Close had her genome sequenced. She's the first named female to have her genome sequenced. So I called her this morning. She's a friend. And I said, so what did you learn? What did you get out of it? And the reason she did it, and she's public about this, is that bipolar disease and schizophrenia runs in her family. They didn't find anything specific in her genome, but what she's going to do now, my second question was, are you going to have your family members sequenced? And I think, would we agree that's where the value is? That would be good value in doing that, extended family and all of that.
Yeah, I think that's a very powerful application, absolutely.
Yeah.
More so than random people.
Now, while we're on the New York Times series about the Human Genome Project, how many of you read that last month? Good, most of you, good. And so I'd love your response to this too, Sue. My response to it is, I think, first of all, 10 years ago when that project began as big science and big funding, it was probably a problem of expectations and how it was presented, because it was presented as a blueprint, but that's not the way biology is. It's not like something you can architecturally take and then go design drugs and create health. It's the scientific foundation. The articles did not mention the first applications that have come out of that I'm spending most of my time on, which is molecular diagnostics. And it's being extremely valuable in that. So the way we develop these new diagnostics today is that we start with the doctor and the patient sitting in an examination room trying to make a very difficult medical decision, which is generally going to result in expensive intervention and treatment program and is poorly informed. So that could be cancer, heart disease, rheumatoid arthritis, a lot of different diseases, obesity, and so on. And so predisposition to diabetes. And then we go back to, okay, what biology speaks to that and what biological networks speak to it. Then we look at, is that measured in gene expression or proteomics? And then what tools or machines would be best for that? Fluidigm or RT-PCR or sequencing or proteomic measurements, just simple what we call ELISA or antibody testing. Then we go back to where can we get thousands and thousands of patient samples of people who have those diseases and go back 10 years so we can see what happened to their progression. And then we assemble a company and get going. And to give you a quick example of why that's important and touches on healthcare economics, is an example is one company, Genomic Health, has developed a test called Oncotype DX that works on breast cancer samples from women diagnosed with breast cancer. And those samples are sent to the central lab of the company. They're analyzed for 24 genes, and then an algorithm speaks to giving an index risk score of progression and also of chemo response. And now 150,000 different patients have been studied and tested by that. And what they have shown in rigorous clinical trials in hard data, peer review published, which is key, is that 90% of women get chemo and only 10% will benefit. So the outcome of that is not only better for the patient, of course better for the patient, those women who don't need it, and when their tumor, individualized form of their tumor, individualized medicine, don't need to have the chemo. Also, the healthcare system can forego all the costs of what's not going to be efficacious to begin with. And I could give you dozens of more examples. Now this gets to something the three of us are very passionate about, which is data-driven. And Sue, I'd like you to talk about that now that you're chancellor of UCSF, a huge healthcare delivery system and hospital and academic medical center. What is it about the data now, and how is that going to change delivery of healthcare?
Well, let me give a real example, Brook, because I think the talk that Stephen just gave is such great food for thought from a big picture level of delivering healthcare for hundreds of thousands of people. I like your example of cancer stem cells. So there's three things that we can all do that most directly will affect our health. Preventive, focusing on health, not disease. Tobacco cessation, vaccines, and colonoscopy. So what if, when you have a colonoscopy and you had a polyp, you could actually measure those crypts, those cells, at the lowest end of the polyp and look at the determinants, and patient 1 might have a risk for cancer. Patient 2 at their colonoscopy might not have a risk at all. So what I think is most exciting about these new technologies is our ability to go into a complex, disease-oriented health delivery system and start to transition where we need to go to a health system. So thinking about how we can do what I think is the most important aspect of the new technology, which is predict the future. It's one of the biggest challenges that we have in health. And when we see neonates, newborn babies at UCSF, I wish we knew, what should we, besides vaccines, which we already know, what should we care about with this child? How should we think about what their parents should think about? Think of how different it would be if we started, I'd start in the womb, even before the child's born, starting to think, what are the interventions? What are the healthy behaviors? What are the things that this particular child, or these groups of children, should be more aware of? So I think what's so hard today is that we spend our time, energy, and money, as you all read about, it's a big part of healthcare reform, on illness and sickness. And what we're all pushing ourselves to ask is, as a major research institution, as Stanford is, how do we start to challenge ourselves to connect two things that are too often disconnected? The great explosion of science and the reality of taking care of people who are ill.
Because prediction and prevention is much less expensive than rescue medicine.
Without a
what we have
doubt,
now.
without a doubt.
So we're all optimists because this is going on now. So this revolution is happening and it's spreading and it's being taught in medical centers. But doctors are slow to change and slow to adopt new technologies. What can be done about that?
Well, I think some doctors are slow to change.
I should have said that.
I think that the opportunity we have at UCSF and the opportunity that academic medical centers have is that we don't only take care of patients, we don't only do science, we teach. And one of the great opportunities is to think about the curriculum, to think about what you teach, how you train the future healthcare providers. The individuals who come to us as students are both much more connected, using social media, understanding the new biology, but they also understand the social concerns that all of us have about healthcare and healthcare costs. So I think that openness to change, that openness to invention, to innovation, to thinking more about health starts with how we train the future healthcare providers, not only doctors, but nurses, pharmacists, other healthcare allied professionals.
Yeah.
Now, could we extend?
Just add, at Stanford, the Dean of Medicine has taken a very similar position, and it's why their first ever undergraduate department in the School of Medicine at Stanford is the bioengineering department, which I helped to start, because his goal is that the future medical students they get out will be trained on the interface between engineering, the physical sciences, and biology for exactly these reasons. It goes all the way back to the undergraduate training.
And we've just started, together with Andy Grove, a Master's of Translational Medicine, to try and bring engineering and the kind of thinking that is much more common in IT and engineering about prediction and making things regular and controlling a system, which in biology and in the life sciences we haven't had.
Now there's a curiosity in the audience and in the general public about drugs, drug development, the time it takes, the costs to do all of that, FDA regulation, risk of drugs. We've all been reading in the press about that recently. When you were at Genentech until a year ago, you introduced more blockbuster drugs really than almost anyone else in the past decade. What is your view now of where we're headed with that?
Well, like many people, I have this combination of incredible optimism about the explosion in science. I mean, if you think of what the technology that we just heard described enables, we know so much, and we're going to know so much more so quickly that virtually anything is possible. So I start from a position of incredible optimism about the explosion of science, and then the reality of the cost and the uncertainty and the complexity of making new medicines. So what I'm most excited about now, and I think that's where technology and the economy really come in, and the themes of this conference, I hope and I expect that we'll be able to tap into the concerns about healthcare costs and healthcare reform as we go electronic, as we know more about electronic health records, bringing in the kind of big science so that we can do product development, we can do trials and product development within the healthcare system. Today, the healthcare system is here, drug development is here, filling out forms, doing things that take years and years, and big science is here. And the opportunity for all of us, and what I saw in my time in product development, is the closer you get to the patient themselves, not some lofty aspiration, but what's the patient's outcome? And understanding how the patient's outcome relates to their sequence, relates to their risk of disease, and ultimately their benefit, I think that's where we can use the technology in ways that we never have before. So we can have literally hundreds of thousands, if not millions of patients worth of information quickly.
Okay, and that's in terms of what we would say in social media, a social graph. And so in the not too many years from now, there will be millions of patients in social networks or linked together with their genomes sequenced. The privacy concerns will be handled. They will be able to choose what levels of interaction they would like to have or people to view their data. They can opt in. That data will be reviewed by people doing all the things we talked about. So let's turn to